Hi everybody, Dr. Pientka once again with another hand lecture for you all, coming to you from theorthopods.com and fortworthhandsurgery.com. Today I'd like to talk to you a bit about digital revascularization and replantation. Starting out, we're going to talk a little bit about the first aid and the indications for replantation. We'll also talk about technical considerations, postoperative care, and outcomes and expectations. And these are really important, especially when you're first seeing these patients in the ER, because this can be a very traumatizing injury for these patients. And you want to set clear goals and expectations from the very beginning, and that can really help with patient satisfaction in the long term with these injuries. So let's get started. So when you have an amputated digit, what are you going to do with the amputated part and the stump? Well, you need to treat them differently. The amputated part is going to be placed in saline moistened gauze, and then that amputated part will then be placed in a cup or bag, the bag placed into a container with ice. And you do want to avoid direct contact of the amputated part with ice. You can place the amputated part in a cold solution like saline or something like that if you need to, but it is best to put it in a separate container inside a container of ice. Now, the hand or the amputated stump, you do want to dress with, again, saline moistened gauze, but you want to hold pressure, and you really want to avoid tourniquets if possible, because what the tourniquet does is that increases your ischemic time to the remaining digits, especially if you have multiply injured digits but only one that's amputated. You can directly affect your outcomes if you place a tourniquet unnecessarily for these. There are studies coming out from all over the world. A lot of these studies come out of Asia. This one does not, but this is a study showing that the volume of replantations that a hospital performs really has a direct effect on the success rate. And this is why there's been a push towards consolidating towards replantation referral centers or regional centers, because you get a higher volume there and better results overall when you have a higher volume surgeon and a team who's familiar with these cases. So when the ER doctor calls you and says, well, doc, the finger's off, what more do you need to know? Well, there is a lot more you need to know with these injuries because, again, they're not all the same. This hand, for example, is not a great replant candidate. You have segmental injuries, you have significant soft tissue injuries. The mechanism of injury and the status of the hand, the remainder of the hand, is important in considering treatment for these patients. You do want to know their hand dominance, although just because it's not their dominant hand doesn't mean that you shouldn't attempt a replantation. Their occupation and medical comorbidities are extremely important to set expectations for these patients. And then smoking status. This is a really big one because the smoking status, if a patient's an active smoker, it portends a 30% decrease in the survival rate for digital replantation. So, a non-dominant index finger in a smoker is something you talk seriously about that patient. It may not be worth trying replantation, or you at least need to set the expectations for these people that, today is the day that they stop smoking if they want their fingers to live. What about when the ER calls you with a revascularization consult? Doc, the finger's hanging on by a thread. What else do you need to know? Well, these can have a wide range of injury severities. To a lesser experienced provider, this may be something where they can't find a Doppler signal distal, but to us, this is a minor laceration on the finger, and we know that this is not a dysvascular finger. But sometimes they look like this, and this is a crush injury. This is a multiply injured digit. This is one where the index finger, for example, should be reduced before you know whether it's dysvascular or not. It could be kinking just because of the degree of displacement of the fractures. They also can be saw injuries, kerf injuries that maybe don't look so bad from the outside, but then you look at an x-ray and you can see that, yeah, this thumb tip probably is dysvascular. And again, being a thumb, this is something that you'd want to jump on. Using pulse oximetry to determine the extent of disc vascularity is actually something that can be done very easily down in the ER, especially with these distal tip injuries where it can be tough to find a Doppler signal even in a vascularly intact digit. But the study here out of PRS showed that there was not a single digit that had a pulse ox reading of at least 95% that had an ischemic injury. And if the pulse ox on the digit was 84% or lower, then that was a dysvascular digit. In every digit that they looked at, 49 total digits that they looked at, and these were consistent among all digits. Now, it is important to know that you need to reduce the fractures and dislocations and warm the digit in order to get a good reading with a pulse oximeter, and consider chemical sympathectomy with medications to decrease the vasospasm can also help before rushing these patients to surgery. So let's talk a little bit about indications and contraindications for replantation and revascularization. Now here you have a multiple digit injured hand. This is an indication when you have multiple digits off to attempt revascularization, or in this case, replantation. So your indications: any part in the thumb, multiple digits like we just talked about, a partial hand amputation or a through palm, almost any part in a kid. Kids do really well with these injuries and don't get the stiffness that adults do. So even a zone 2 injury in a kid doesn't have the same poor prognosis that it does in an adult. Anything, certainly wrist or forearm level, should be tried. Elbow or above, if it's sharply amputated, is an indication for replantation. And then any individual digit in zone 1, so that's distal to the FDS insertion. And a reason for this is, one, you don't get the stiffness that you do in zone 2. Two, you can do artery-only replantation for these distal injuries where you pop the nail off and use either heparin pledgets or some scraping and bloodletting from the nail bed in order to allow the veins to reconstitute. And that can allow a distal type injury to survive. Now, contraindications. Urbanek in 1985 talked about different contraindications, and these are the severely crushed or mangled injuries, like we saw in several of the slides earlier. Amputations at multiple level or a segmental amputation, those are not candidates for replantation. Patients that have other serious or life-threatening diseases, patients that have severe atherosclerosis, psychiatric history, somebody that cut their own finger off is not a candidate for replantation if it was intentional. Prolonged warm ischemia time, and what we mean by that is, a digit that is dysvascular but still attached has a 12-hour warm ischemia time before the chances of viability drop off significantly. Now, if it's proximal to the digit where there's muscle involved, so through palm or proximal to the carpus, that drops to about 6 hours. And if you wait longer than that, what you get is the muscle starts to die. You get a creatinine kinase bump, you get a CK bump, and they go into kidney failure as that muscle sort of releases all those cytokines that affect the kidneys. Now, cold ischemia time, if you have a fully amputated digit, you got up to about 24 hours is the standard if it's been on ice, but there's some studies out there that show that it can be replanted up to 90, 94, 96 hours after the injury. Now, you don't have more than 12 hours of cold ischemia time when there's muscle present. So it's important to evaluate the amputated part because if you see the signs that you see here on these images, these are really bad indications for success. On the left, what you see there is a red line sign. And what the red line sign is this is a indication of injury along the neurovascular bundle, specifically the artery, all the way along that bruising there. So even though your amputated part is proximal to this, you do have intimal damage and arterial damage the entire length of that digit. And if you don't do something like vein graft to compensate for that arterial image, this is going to not have a good success and become vascularly compromised once again. On the right side of the screen, what you see is the ribbon sign. So this is an avulsed injury where you've got your artery has pulled out. You also have a multiple level injury of the digit here. And this really is something that's going to have a lot of intimal damage in that artery and not be a good candidate for replantation. Being able to counsel these patients is extremely important. So what I challenge you all to do is to practice counseling patients on indications and expectations for replantation, and more importantly, being able to explain to patients why they're not candidates for replantation. So let's talk a little bit about the technical considerations of replantation. It's important to have a division of labor and a specific sequence of repair. And a lot of this starts before the patient even gets into the room. So you evaluated the patient in the ER prior to bringing them up to the operating room. And you take the amputated part and you take it up to the operating room and you set up a back table and you start preparing that part before the patient even comes in the room. This is a great way to decrease time of anesthesia, tourniquet time for your patients. You're going to prepare the amputated part. You're going to tag your arteries and your nerves. You're going to identify your tendon structures. You're going to place your sutures or K-wires. You're going to shorten the bone if you need to get a cleaner repair. And this is all done before the patient's even rolled into the room. The patient rolls into the room and you need to start working on the stump. We start with the big structures, the macro structures, and you need bony stability before you can do any sort of microsurgery for these patients. And then flexor and extensor tendons, quickly you can suture these and get these out of the way. When you're doing your bony fixation, whether you're using longitudinal or crossed K-wires, whether you're using 90-90 wires with a 18-gauge wire, these are, whatever you do, you need to do it quick because your tourniquet time really needs to be used for your microsurgery. Once you've got your bone and tendons fixed, then you're going to move on to your microsurgery. And I like to do the nerve first. It's relatively quick. You cut back to healthy appearing nerve fascicles, graft primarily if you need to. And then at this point, you can go down with your tourniquet and do your arterial anastomosis under local arterial clamps, but where you can make sure that you've bled out any clots, that you've really cleaned up your anastomosis site, you've identified any intimal damage, and get a good arterial repair. And then finally, once your arterial repair is done, that's when you're going to turn your attention to trying to identify and repair veins on the dorsal aspect of the digit. So when you're preparing, you do want to identify all the structures, but shortening the bone has several benefits. When you're working in the digit and you shorten by 5 to 10 millimeters, or more proximal, you can even shorten by 2 to 4 centimeters. The benefits of this, you take tension off of your arterial and nerve anastomosis. You can get more flat cuts, as you see on the top left there in the cartoon, where you can get better bony opposition. You really take a lot of tension off. You decrease the tension on the skin when you're closing as well. So there's really a lot of benefits of shortening the bone when you're doing these sort of cases. Bony fixation, like I said before, you can use longitudinal K-wires, which is A. You can use 90-90 wiring, which is B. C is crossed K-wires. You can put screws inside the bone, or you can put plates. Really anything you want to use here is fine, but just remember that shortening is a necessity when you're doing these cases. Your tendon repairs, I like to do my extensor tendon repairs with a 4-0 fiber wire suture. You can use a mattress suture, that's pretty quick. I tend to use a modified Kessler suture, which I feel like is also pretty quick. I do that even when I'm not doing replantation, so it doesn't change my normal techniques. Flexor tendon repairs, normally you're only fixing FDP. Now if FDS is there, you can repair it, but by doing so, you increase the risk of adhesions My preferred technique is the limb psi method for this, but you really can do your flexor tendon repair in any technique that you are comfortable with. When it comes to arterial repair, there's no real standard on how many arteries you need to repair. Now, the more you do, the better chance you have of success. Size mismatch can occur, but you can overcome this with just standard microvascular techniques. You can do oblique cuts in the vessel to gain size. You can use vessel dilators. You can do end-to-side anastomoses. You sometimes need to vein graft these. And if you do need to vein graft, the studies show that it does decrease survival of the digits, but there's some unclear evidence on, is this because of the vein grafting or is it because it's a worse injury that requires vein graft? I tend to think if it requires vein graft, it's probably a worse injury, which is why it's less likely to survive. You do want to make sure, especially if you're taking a graft, that you do not anastomose the vessels under tension at all. That's the most common reason for failure, is that you anastomose under tension. You can harvest your veins right from the wrist. You can get them from the foot. You can get them from the forearm. There's lots of places. And if necessary, you can even do a cross-finger anastomosis. But you really want to make sure before you leave the room that you've got a good arterial anastomosis, at least one artery. But again, if you can do both, that's absolutely better. The nerve repair, again, we want to try and give patients sensate fingers. This is critical, especially on the radial aspect of the index finger, the ulnar aspect of the thumb, for example, where you're really getting your pinch. Patients really struggle if they don't have sensate pinch. Proper coaptation of the nerve is critical to decrease the risk of developing painful neuroma. So this is using your epineurial sutures. I use an 8/0 nylon suture under standard microsurgery techniques, and I have a very, very short fuse or low threshold to use a primary nerve graft. I'm a big proponent of nerve allograft, but autograft is certainly acceptable here as well. Now your vein repair, the veins, as I said before, in the subcutaneous tissues dorsally on the digit. And if your veins are too short, even once you've shortened your bone, you can achieve additional length by ligating sort of side branches and creating a single pipe to elongate those veins. And if this is performed after the artery, it's certainly easier to identify, but it will bleed and can make visualization a little bit more difficult. Just like the arteries, the more veins you repair, the better off you are. You do want to have a ratio of at least 1 to 2. With if you repair one artery, you want to repair 2 veins. And your venous congestion is a very common cause of early failure in these patients. Venous arterialization is something that has been reported for amputated digits, and this is where you basically take the artery and sew it to a vein in the amputated part to establish inflow, and the proximal vein is then anastomosed with another vein to establish outflow. In this small study with 6 digits, all survived. They regained good sensory and motor functions and had no difference from thumbs that had standard replantation. So that is something to consider as well if you don't have a distal artery to plug into. Postoperatively, these patients do require higher level care. They need hourly monitoring. They may need anticoagulation and blood transfusion, possible leaching for venous congestion. And these recovery is really similar to a free flap. So the clinical exam is king. You do need to identify failures early on these so that you can hopefully take them back and revise if needed. As far as failures go, digital spasm, arterial spasm is a very common cause. Arterial thrombosis, external compression, venous thrombosis, and infection are all other causes of early failures, and we'll go through each of these individually. So let's talk about vasospasm first. An arterial spasm is really a common cause of early failure that can be seen with increased pain, decreased temperature. It can be due to mechanical stimulation. You can get this from dietary sources, caffeine, for example, peppermint, different vasopressors or even nicotine. This is why smokers have a worse prognosis with digital replantation. Thorazine is a medication that you can use to perform a chemical sympathectomy or to release that sympathetic spasm. And then warming the digit and minimizing manipulation are things you can do to try and decrease this. You can also consider brachial plexus blocks or regional blocks to decrease the sympathetic input on these patients to hopefully block their spasm. Now, this study only had 16 patients, but they did find that brachial plexus blocks were effective in providing a sympathetic blockade and pain control in patients after digital replantations and toe-to-hand transfers. Lots of studies out there talking about caffeine and the chocolate, which has caffeine in it. Various reports. Some say caffeine has a vasoconstrictive effect. Some say it doesn't. Chocolate does contain caffeine, but also has other vasodilators. Habitual users should probably be cautioned not to increase their use and to use with caution, but for non-habitual users, it's probably best to abstain from caffeine. Can you use topical vasodilators? And in this study, they used calcium channel blockers. They were noted to have a great effect on vessel spasm when used topically. Papaverin and lidocaine, which are commonly used, didn't work quite as well, but still had some effect. Moving on to arterial thrombosis. This is causes a loss of inflow, so blood inflow into the digit, and this patient will have a cool, pale, ischemic-looking digit, and the gold standard treatment here is surgical. You need to go in and remove the clot and probably revise your arterial anastomosis in order to get these digits to live. External compression. Now, this is something, in orthopedics we see as a cause of compartment syndrome and things like that, but this can cause early failure in these replantations and revascularization as well. And then venous thrombosis. Now, venous thrombosis is another problem. And if you have a digit that looks like this, the first things you want to do, remove sutures to decrease pressure on the anastomosis site, remove the nail plate, and consider Heparin pledgets. Medical leeches or systemic anticoagulation can be considered. You really need a graded approach and a systemic approach to how you, a systematic approach with how you address these. You want to ensure there's no external compression. You want to ensure there's no internal compression or hematoma under the skin flaps, so you're popping those sutures. If you are planning to take the patient back to the OR, which is probably favored unless you feel like that you had a tenuous repair to begin with and you can't do a better job, take them to the OR, explore the vein, be prepared to do a longer vein graft if you need to. If you don't feel like the patient's a good candidate to take him back to the OR, then your goal has to be for your blood flow to come through the artery across into the amputated part and then onto the floor. So mechanical bloodletting, leaching, and prepare that patient for a blood transfusion. Now, veins will repopulate with time, but you need inflow, and this venous congestion will prevent your inflow. So you need to do something to prevent this or relieve this in order to prevent the digit from dying. What about prophylactic anticoagulation? Heparin, Lovenox, aspirin, dextran, these are all out there and really up to individual surgeons for use. They all have risks, bleeding from the surgery site or the GI tract or even intracranial hemorrhage. Dextran historically has widely been abandoned due to side effects, including anaphylaxis and pulmonary edema, as well as renal failure. And there's large studies out there that really failed to demonstrate improved survival of digits with prophylactic anticoagulation, specifically with heparin. But many surgeons will agree that anticoagulation of some sort should be used unless there's some sort of patient related factor that would cause you not to want to do this. Routine heparin use is really not indicated. Extenuating circumstances, though, if you have anastomotic complications, a large crush area, if they're hypercoagulable at baseline. We don't know exactly how long to do this for. I think the standard in most places is 5 to 7 days. And then finally, a devastating early complication is infection. The patient that has a finger like this, there's no saving this. You need to go in, remove the finger, get the infection under control, and it's a time like this where this can really even become a limb or life-threatening issue if it gets into a necrotizing fasciitis or something like that. So this needs to be addressed and recognized early. With these infections, you want to debride, and you want to debride liberally. If there was any gross contamination or a farm-related injury or water-related injury, there's certainly guidelines out there on what antibiotics to place them on prophylactically. You do want to cover for gram-positive and gram-negatives, and there's antibiotic suggestions on the slide here that you guys can see. And then when do these patients go home? Well, the patients, it's not a quick looking. As far as expected outcomes, this is where being able to counsel your patients becomes important. Their ability to return to work has a lot to do with what their occupation is. A lot of times these patients will have delayed bone healing. It may take several months in order for them to have a stable digit, and then they're still working on rehab for their tendon injuries, and they have an insensate digit for months. So it can be several months until these patients are back to the workforce. Oftentimes these patients do require revision surgery, whether that is tenolysis or bone grafting or something down the road. It is something that the patient should know that they may require revision surgery. Now our goal is a pain-free sensate hand with minimal disability. But they can have chronic pain, they can develop cold intolerance, and stiffness are very common occurrences after replantation. And then, of course, aesthetic concerns are very culturally, for sure, and you need to be able to take those into account when you're counseling these patients as well. Lots of studies out there that talk about replantation versus revision amputation. A lot of single-digit amputations are now just being revised in the operating room because of the cost, the downtime, and the really minimal disability that causes in patients. But functional outcomes after replantation can be improved, again, by developing regional replantation centers where you have higher volume centers with a more well-tuned team. So here's just some articles that you can look at that talk about the pros and cons of replantation versus revision amputation for different levels. And hopefully that spurs you guys to look into this a little bit more. I want to thank you all for your attention. Again, please follow us on theorthopods.com. Feel free to comment on videos here on the YouTube channel, and reach out to us if you have any interest in either contributing or any topics that you'd like us to cover in the future. Thank you very much.